Well, hello. My name's Trevor Duke. I'm a pediatrician, and this is another teaching session based on the Pocketbook of Hospital Care for Children. The Pocketbook of Hospital Care for Children was produced by the World Health Organization in 2005, and the second edition, this is the second edition, it was produced in 2013, and the third edition is currently underway. The Pocketbook of Hospital Care for Children contains guidelines on the management of all common diseases in children, newborns, children, medical and surgical conditions. It outlines a standard approach to the management, an up-to-date evidence-based current approach. It emphasizes a systems approach to the management of children in hospitals, and it is focused on the care of children in hospitals that have limited resources, such as district level hospitals in rural areas. But it's also relevant, highly relevant to secondary referral and tertiary hospitals that also see children. If everybody followed the guidelines in the Pocketbook of Hospital Care for Children, there'd be the quality of hospital care for children would be much improved. The accompanying the Pocketbook, the guidelines book, is a training course that runs for 4 or 5 days, depending on the modules that are used. And we are just going through some of those modules in this series of lectures. Today we're going to talk about the chapter 8 in the book, which is a chapter on HIV. Now, quite a lot has changed, certainly since 2005 and even since 2013 in HIV care, but I'll go through the module and we'll update you on the changes as well. Each of these teaching modules is based on a case, on consideration of a case, and teaching. The aim is to teach healthcare workers how to use the Pocketbook in everyday clinical practice. I don't think it's intuitive that people know how to use guidelines in everyday clinical practice. It's good to be taught to learn how to use guidelines in the way we practice. So we'll get into this. As I said, they're all based on a case, and the case today is a child named Thomas. Thomas was a 8-month-old boy who was brought to hospital with a history of fever for 8 days. He'd not been able to eat or drink anything for 2 days prior to the sores in his mouth. And in fact, his feeding had been poor for about 3 weeks, as we learnt later. You can see the white plaques on his tongue and on his lips, and he had that extensively throughout his mucous membranes. I haven't shown you the rest of Thomas for reasons that are sort of obvious later on. Now, remember that the stages of management of any sick child, if seen in a clinic or if seen in an emergency department, are triage, emergency treatment, history and examination, laboratory investigations if needed, making a diagnosis, making a main diagnosis, and then considering other diagnoses, comorbidities or alternative diagnoses, giving treatment, providing supportive care, and monitoring and discharge planning and follow-up. As I've said before, when we looked at the quality of hospital care for children in countries around the world, we found that hospitals were generally very good at making a diagnosis and giving treatment, but they weren't so good in the other processes, especially triage, especially supportive care and monitoring and discharge planning and follow-up. And as hospitals see fewer acutely ill children, fewer children with acute illnesses, and relatively more children who've got chronic underlying illnesses. Chronic illnesses are increasing around the world. Then also hospitals need to be able to provide chronic or long-term care for patients, to be liaising more with primary health care and things. And so in many ways, this case is about not so much an acute illness, but an acute on chronic illness, the acute presentation of a chronic illness, and hospitals need to be orientated to managing children who've got ongoing chronic illness and making sure that they have continuity of care and they have a trusted healthcare worker who can look after them, and they have and a lot of other areas uh, addressed. So it's not just that more children thrive, but survive, but they also thrive. And that means paying attention to other aspects of growth and development and things. So remember a triage, getting back to triage, the first step is there is a simple way to quickly assess for emergency signs. At triage, we're sorting patients into those that have emergency signs, those that don't, those that have priority signs, and those that don't have either, and and seeing those that have emergency signs first, and also addressing their emergency conditions. So you take a brief history of the presenting problem. That's what we heard from Thomas. He has 8 days of these mouth sores or increasing mouth sores over the last 8 days. They'd been there for a few weeks, and he had a temperature. So you take the temperature and weigh the child. You take the temperature because it's important to address whether or not a child's got a febrile illness and likely infection or they don't. And you'd weigh the child at triage just so that any medications that you're giving later would you can calculate the medications and you can assess the child's nutritional state fairly quickly. You should when you're talking to the parents, when you're taking the brief history, you should listen for stridor or obstructed breathing in the child. You can make observations along the way. You should look for cyanosis and other signs of respiratory distress, so chest indrawing or tracheal tug or head nodding or grunting breathing, and you check for the oxygen saturation. And you feel the skin temperature in terms of circulation, you feel the skin temperature of the hands and the feet. Feel that for the pulses for volume, so the radial pulse or the dorsalis pedis or the posterior tibial pulse, and check the capillary refill time. And then you assess the child for lethargy and the degree of interaction they have with you at an age appropriate way. And if you practice this, you can really do this within a minute or two of seeing the child. And I think it's really important to just have a triage process that you can practice and quickly do, because then you'll pick up emergency signs and children will receive appropriate emergency treatment. They can be then triaged to triage category 1, having emergency signs, or triage category 2, having a priority sign, or triage category 3, having neither of those, and then they can be sorted properly. At triage, Thomas's weight was 6.4 kilos, and you could, using his infant record book or using a weight for age chart, you could quickly check his weight for age Z score. We know he's 8 months of age and 6.4 kilos. It's quite easy to do that. We'll do that in a minute. He did look small for age. That was an observation that was made, and he was unwell. He looked unwell, generally miserable. His temperature was 38.2, but he had no respiratory distress. He was not cyanosed. His saturations were okay, 95%. His pulse volume was normal. His capillary refill was 1 to 2 seconds. His limbs were warm. He was alert, but he was irritable and seemed quite miserable, obviously in some discomfort from his oral lesions. This was his weight for age chart, and you can see he's 8 months old and he weighs 6.4 kilos. So that puts him between, oh, that puts him between -2 and -3 standard deviations. And um, and so he's got moderate malnutrition. Remember, assessing um, when you're assessing children at triage, you need to decide if they've got any emergency signs or if they've got priority signs. And Thomas had some priority signs. He had high temperature, he was irritable, and he had malnutrition, moderate malnutrition. So he should be seen. He doesn't need any emergency treatment, but he should be seen quite promptly. So Thomas has no emergency signs, but he has priority signs, which means that he should be seen promptly and have his have the clinical process, the history, and the examination done promptly. So the next step is the history, isn't it? So Thomas was, we know that Thomas was well until about 4 months of age, and then since then he'd had 4 visits to his local clinic and 2 episodes he'd had 2 episodes that needed hospitalization with pneumonia or respiratory infection and treatment with antibiotics. So since 4 months of age, he's been unwell, and during that time, he'd had a couple of episodes of diarrhea as well. And each episode of diarrhea lasted for over a week, with watery diarrhea with some mucus in his stool. And he'd been losing weight really since he'd started to become unwell at the age of 4 or 5 months. He'd had sores in his mouth. They'd started about 4 weeks ago, especially worse in the last couple of weeks, and he'd not been able to eat or drink much in the last week at all. Regarding his nutritional history, Thomas he's still breastfed. He was exclusively breastfed until 5 months, and then weaning food was introduced. So quite a good period of breastfeeding. Weaning food was introduced, and the food that he was eating was rice and vegetables and fish and meat, a relatively balanced diet, some fruits as well. But he'd been eating less in the last week or few weeks because of the mouth sores. In terms of family history, Thomas is the second child of his parents, Teresa, age 20, and Jacob, age 24. Jacob's a mechanic. Teresa was a student, and then she became pregnant with her first child. Teresa had 1 episode of cough and fever and received some antibiotics during her most recent pregnancy with Thomas, and didn't gain the expected weight during pregnancy, but is otherwise well, and Jacob was well. Thomas has a 3-year-old sister named Rachel who's healthy, and the family live in a 2-room house with a town water and electricity supply, a refrigerator, and a septic tank. So they lived in the town. Thomas was on examination, so we've done triage, emergency treatment, but Thomas didn't need any special emergency treatment, but he had priority signs. We've taken a history, and on examination, Thomas was alert, but he was miserable. He looked a bit pale and had some muscle wasting, but he was not cyanosed or jaundiced. He didn't have respiratory distress. He had some enlarged lymph nodes in the inguinal region and the axillary region and submandibular region, and they measured between 1 and 2 centimeters. They seemed more large than what would normally be seen. His temperature was 38 degrees, 38.2. His pulse rate was 120. His respiratory rate was 30. We saw that he was between -2 and -3 standard deviations below the mean in terms of weight for age. And as I said, in his mouth, he had these white plaques on his gums and right through to the back of his throat. When you look with the spatula, right through to the back of his throat. His skin was quite dry and he had some flaky sort of rash on his skin, but he had no respiratory distress, and his chest was otherwise clear to auscultation, and his cardiovascular system was normal. In terms of his abdominal examination, he had liver palpable 4 centimeters below the right rib margin, the right costal margin, and his spleen was enlarged 5 centimeters. So he's got lymphadenopathy, hepatosplenomegaly, what looks like white plaques all throughout his mouth, what looks like oral thrush. So he's got a number of features of being unwell. So the differential diagnosis, clearly he's had recurrent infections. He's had 2 episodes of diarrhea and 2 episodes of pneumonia or respiratory infection. He's undernourished. He's got moderate malnutrition, and he's got lymphadenopathy, hepatosplenomegaly. So you would suspect an immunodeficiency of some sort, and you would suspect HIV. You'd be interested to know whether his mother was tested antenatally for HIV. She wasn't. She didn't have any antenatal screening for HIV, although she did attend antenatal care. And the other possibility is that some sort of congenital immune deficiency that can look exactly like HIV. So you'd want to explore that. If you are seeing a child who you suspected may have HIV, then you could look for other features that would suggest HIV. They can also be seen in children who have any form of severe combined immunodeficiency, but more commonly in children with HIV. And you can look up these features in the Pocketbook. Chronic parotitis, which is an inflammation of the parotid glands just in front of the ears. Lymphadenopathy and hepatosplenomegaly, which Thomas has. Persistent or recurrent fever, which we know he has. Herpes zoster, which is an infection that some children with HIV have, but then other children who are immunocompetent, normal immune function, can also get. and then dermatitis, chronic suppurative lung disease in older children typically, not so much in infants, but chronic bronchitis or bronchiectasis is relatively common in children with HIV, and persistent diarrhea. These days, with antenatal testing, then it's very uncommon to see these severe opportunistic infections. And if children are tested, if mothers are tested antenatally and they're diagnosed with HIV during pregnancy, then usually children can be tested and go through the prevention of parent to child, mother to child transmission program, and then get then it avoids getting the clinical features of this immune deficiency. Now, still some mothers will not have testing done for whatever reason. It's not available at the antenatal clinic, and they may then be more likely to give birth to children who have HIV. This is herpes zoster. You can see it's shingles. It's a vesicular infection that you can see. It's from the chickenpox virus, but it's not a widespread rash that's all over the body. It's really just in what we call a dermatomal distribution, and it's vesicular in nature. It's usually on one side of the body rather than both sides. This is herpes zoster in not a child with HIV, but in a child who didn't have an immune deficiency. So most infections that children with HIV can get also rarely children without HIV can also get. So what investigations would you like to do? Well, firstly, it's useful to do a full blood count. You might want to swab Thomas's mouth for fungal microscopy to see if there's thrush there, although it looked like oral thrush to me. And you do a HIV test. After counselling his parents and seeking consent, and these days PCR testing is done on a dried blood spot, or it can be done on venous blood, and that improves the diagnosis for children under the age of 18 months. Before, it was necessary to wait until a child was 18 months to be diagnosing HIV, or it was diagnosed on clinical grounds like Thomas's clinical features. But now PCR testing, which is widely available, can be done from the time of birth. So as soon as a child is suspected of having HIV, then a PCR test, which is a test of looking for the nucleic acid. It's a nucleic acid test that looks for the viral particles in the bloodstream. The test that can be done from 18 months of age just looks for antibodies, but babies and infants may still have antibodies from their mother in their bloodstream, and it doesn't mean they have the infection, they just may have the antibodies. But PCR testing is much more a specific test for HIV infection in the child under the age of 18 months. This was Thomas's full blood count, and you can see a few things from it. His hemoglobin was a bit low, and we thought he was anemic, or he looked pale. His platelet count is normal. His white cell count is normal. His neutrophil count is just a bit elevated, which might suggest he's got a bacterial infection of some sort. And his lymphocyte count was quite low. Now, not all children who have HIV, their lymphocyte count will be low. But if you see a child with a low lymphocyte count, then that may be a marker of immune deficiency. It's often also seen in a respiratory, in other viral infections or other infections, and it's usually a transient phenomenon that will recover. But if you see a persistent lymphopenia in a child, then it's likely they have immune deficiency. So if you see it once, then arrange to measure the full blood count again and the lymphocyte count again at least a week later. And if they still have persistently low lymphocytes, then you should be concerned about an immune deficiency of some sort. So Thomas's MCV was 67. Remember, we have talked about how if a child's got a low MCV, they've got small red cells within their blood, and small red cells are microcytic, and microcytic anemia is likely to be iron deficiency. So Thomas has some signs of iron deficiency on his blood film. So he's got signs of infection, signs of iron deficiency, and signs of immune deficiency with lymphopenia. Thomas's parents were then counselled about the possibility of HIV. It was obviously a big shock to them because they didn't realise that Thomas could be that unwell. And although they'd taken him to the clinic on several occasions in the last few months, but that was explained to them the implications for them and their family. Obviously, it's most diagnoses in children that doesn't have the same implications for the parents. If a child's got HIV, then it's likely, highly likely, that one or both of the parents will have HIV as well. And but these days, it's important to explain not just that implication, but the implication being that while they are well, if they get onto antiretroviral therapy, then they can remain well. And it's very different these days to what it was 15 or 20 years ago when HIV treatment was in its infancy. And it wasn't possible to reassure people that if they got onto ART, then likely they would remain well. And that can be an incentive to be tested to prevent oneself getting sick. And so Thomas's parents agreed to the test and to have for them to have tests and for Thomas to have a test. Some parents will only agree for the child to have a test, but they need to understand what the implications are for them if the child's test is positive. And sometimes you can just then do the child's test and then counsel them again about that they really should be tested so that they can get onto treatment and so they can prevent further spread of HIV with a subsequent pregnancy or with other sexual partners. Now, Thomas had a positive PCR test, and his mother and father also both Teresa and Jacob were positive HIV. That for anyone over the age of 18 months, then an ELISA antibody test is sufficient, and that confirms the diagnosis. They had a repeat test to confirm the diagnosis. Their other daughter, Rachel, had a negative HIV antibody test. She was 3 years of age, so that means that she doesn't have HIV. So Thomas did have HIV. Not surprisingly, his mum and dad had HIV, but his sister Rachel did not. So in the past, we used to stage HIV a lot, and that had big implications on whether or not antiretroviral therapy should be started or not. That was in the days before PCR testing, before we could be very clear that the child had HIV. We used to do clinical staging. It's still useful to have some idea of clinical staging of HIV, but it's not as important these days. And the reason being is because a positive test means that a child should be on antiretroviral therapy. It used to be that it was more as much based on the clinical stage. So the question of treatment, we've talked about triage and emergency treatment, prioritization, history and examination, a diagnosis and a differential diagnosis. And we've thought about the differential diagnosis of a child who's got an immune deficiency. We've done some investigations to help support the diagnosis and a definitive investigation that confirms the diagnosis, and now treatment. And as I said, it used to be that children were started on antiretroviral therapy largely based on either their CD4 count, which is a component of their lymphocytes. When you look at lymphocytes, there are B cells and T cells, and when you look at T cells, there are CD4 cells and CD8 cells. There's other ones as well, but they're the main ones. And we used to only start the HIV virus attacks, especially the CD4 cells, and reduces them, and that means the child is severely immunodeficient. And we used to only start if the CD4 count was low or if the child had a certain staging. But as I said, now it's test and treat. If the test is positive, whether you're under 5 years of age or over 5 years of age, it's usually certainly under 5, test and treat. Over 5, if you can do CD4 testing, and as I said, that's a component. It's one type of lymphocyte. You could have all the other lymphocytes could be relatively normal, but if your CD4 count is low, or less than 500, you should definitely start treatment. But most hospitals now don't have CD4 testing as much as they used to, and so all children who are confirmed HIV positive on PCR testing should be treated. And there are HIV antiretroviral therapy is complicated. It's all described in the Pocketbook of Hospital Care for Children. There are four classes of ART, and there's some older drugs that were around in the late 1990s, and there's some newer drugs that were really have been around for 15 years, and then there's some other drugs, the integrase inhibitors that have only been around 5 to 10 years. The four classes of drugs are nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, which became available in about 2010, and then integrase inhibitors, which really started to become more available in 2015, 16, and now standard of treatment. And the reason why there has had to be a change in treatments is twofold. One is that some of the earlier antiretroviral therapies had quite a lot of side effects. And so there was always a drive to have medications with fewer side effects. And the other reason is because there's been growing HIV resistance to the earlier antiretroviral therapies, and that's particularly the case for non-nucleoside reverse transcriptase inhibitors, especially nevirapine. And nevirapine used to be a standard medication drug used as part of the ART approach, and now the many countries have nevirapine resistance rates of 15 or 20% or more, and WHO recommends that if it's exceeding 15%, then you should not use nevirapine. And so then in recent years, around 2010, new regimes with lopinavir, ritonavir were introduced, the protease inhibitors, and now WHO recommends that all children should be on an integrase inhibitor-based regime. So 3 medications, one including an integrase inhibitor, and for most children, apart from neonates, for newborn babies, then the treatment is dolutegravir. Dolutegravir is the base treatment for most therapies, and then including usually 2 non-nucleoside reverse transcriptase inhibitors, lamivudine and abacavir. That's first line treatment. So abacavir, lamivudine, and dolutegravir are the 3 most commonly recommended antiretroviral therapy regimes that are available for children these days. And it's only in the last few years, but there are now dispersible tablets, 10 milligram tablets of dolutegravir, and so therefore even younger children can receive dolutegravir-based therapy, and all children, if they're on some other ART, generally should be changed to a DTG-based regime. Raltegravir is used for neonates. We won't talk about that too much. This is the latest WHO recommendation for antiretroviral therapy. So for those under 30 kilos, abacavir, most children, abacavir, 3-TC, which is lamivudine, and DTG, which is dolutegravir. That's the preferred first-line treatment. For older children, adolescents, tenofovir and lamivudine and dolutegravir. It's still a DTG-based ART regime. There are alternative first-line regimes and second-line regimes for children who get develop side effects, or if resistance occurs. As I said, the new DTG 10 milligram dispersible tablets makes DTG appropriate for under 3-year-olds. Before that, it wasn't possible for them to have DTG-based regimes. If a child's got TB and HIV, then you need to double the dose of DTG while the child's on anti-tuberculous therapy, because of the effect of those drugs on the anti-TB drugs on DTG levels. And so you need to double the dose so that they maintain an adequate blood level of DTG. For neonates and infants, abacavir, lamivudine, and raltegravir, as I said. But for most children, it's abacavir, lamivudine, and dolutegravir. In children who have HIV, they often also have other infections, and Thomas was the same, of course. He had a few episodes of persistent diarrhea, and he had oral thrush. So that the Pocketbook of Hospital Care for Children outlines the treatment for those conditions, those opportunistic infections that children have. All children with HIV should be on cotrimoxazole preventative therapy. So that's a form of supportive care, if you like. Cotrimoxazole supportive therapy should be given to all children. Even older children and adolescents can benefit from it. Cotrimoxazole supportive preventative therapy began to prevent pneumocystis pneumonia, pneumocystis jirovecii pneumonia, which is a very common form of pneumonia which still occurs in infants who have immune suppression from HIV, and but it's less likely to occur. It's certainly less likely if a child's on antiretroviral therapy and if they're on cotrimoxazole preventative therapy. If a child lives in a TB endemic area, or if they're exposed to tuberculosis, then they should be on TB preventative therapy as well, isoniazid preventative therapy, or the shorter course rifampicin isoniazid preventative therapy if they're in a TB endemic area, or if they have any risk of tuberculosis. Other forms of supportive care are common to other children, that is improving their nutrition. And while breast milk transmission of HIV virus does occur, if a child's got HIV, then they should be breastfed fed with breast milk if at all possible, because that will be certainly a safe thing to do, because the child's already got HIV. So Thomas was able to continue breastfeeding and improve his nutrition with micronutrients and vitamin A and zinc, and just improving his diet. And he had anemia and a low MCV, so he's got iron deficiency anemia. His hemoglobin was 8.9, so he needs to be on iron supplementations. He should continue having all his vaccines, especially once he's got on antiretroviral therapy and he's got immune reconstitution, except for BCG. Thomas had his BCG at birth anyway. But if a child's got HIV or HIV exposed, then it's better not to give BCG until you confirm or clarify what the status of the child actually is. All children families need additional supportive care with psychological and social support and general kindness, don't they? They need to know that healthcare workers are not discriminating against them, that there's no stigma, that they're going to be supported. They're going to have ongoing, consistent, comprehensive care, and that they are likely to be well. Monitoring is important for children with HIV, and a lot of it occurs in an outpatient setting, doesn't it? So we need to monitor for antiretroviral therapy. We monitor the effectiveness of antiretroviral therapy, and as I said in the past, we used to do CD4 counting, and you'd aim for a CD4 count within the normal range. That suggests that confirms that the child's got immune reconstitution, that their immune system is now healthy if the CD4 count's in the normal range. These days, CD4 testing is less available, but still important, I believe, still important, and it may actually return as being one of the important ways to monitor children with HIV. But many hospitals now test for viral load, which is the amount of virus in the system, and that's also important. Antiretroviral therapy will reduce the viral load, and the aim is to reduce it to less than 1,000 copies per mil and it might be in the future the combination of viral load testing and CD4 testing would tell us two things. One, the virus is suppressed adequately by the ART, and two, that the virus is suppressed enough for there to be adequate immune reconstitution. Reconstitution means the redevelopment of a healthy immune system after it's been damaged by the HIV virus. So we need to monitor for the effectiveness of ART, for adherence with antiretroviral therapy, and for the complications of ART. So there are in the Pocketbook of Hospital Care for Children, in the HIV chapter, there are many there's a list of complications of ART, but there's a number that are quite common, including anemia, neutropenia, the low white cell count. Rashes are very common with ART, abdominal pain. And if a child's got abdominal pain, then consider that they might have, for example, pancreatitis, or they might have hepatitis. There's a number of things that could be wrong. And they're the common complications. Although, having said that, most children, more than 80% of children who are on ART don't get these complications. It's just that you need to be alert for them when you're seeing patients with HIV, and these children should be seen at least monthly in the HIV clinic, or in the maternal and child health clinic, or yeah, in the emergency department. Yeah. This is just to give you an indication of what immune reconstitution actually means. If a child has, it's age dependent, but if a child has a CD4 count more than 1,500 cells per microliter, then they've got a normal CD4 count. If a child 1 to 5, so less than 1, 1,500, 1 to 5, more than 1,000, and 6 to 12, more than 500. They're the normal levels. And then there's levels of moderate immune suppression, and then there's levels of severe immune suppression. And many children, at least what used to happen, is when they would present with opportunistic infections like Thomas did with hepatosplenomegaly and lymphadenopathy and oral thrush, etc., and chronic diarrhea or recurrent diarrhea, they would have severe immune suppression, and their CD4 count would be very low, like it is in this table. But when the good thing about CD4 testing is you can measure it, and when it's low after they go on antiretroviral therapy, within weeks, often the CD4 count is resolving. When the viral load falls, then after that the CD4 count will rise, and you usually get immune reconstitution within the first few weeks to a month or so of commencing antiretroviral therapy, and sometimes that brings with it some stimulation of the immune system, some inflammation, some what we call immune reconstitution syndrome, where if a child's got some infection that's been a bit dormant, it can become a bit more active, and that immune reconstitution syndrome can be a complication of HIV. That's also described well in the Pocketbook of Hospital Care for Children. We've talked about triage and emergency treatment, taking a history, doing an examination, making a diagnosis, laboratory investigations to confirm it, treatment, supportive care, and monitoring, both inpatient and outpatient. And discharge planning is very important for children with HIV and for any child who's got a chronic illness, because what needs to happen is not that the care doesn't finish when the child is discharged from hospital. There needs to be a continuity of care from hospital care to clinic-based care to outpatient-based care, and the outpatients might be at the hospital, or it might be at a more a clinic, which is a clinic or a health centre which is closer to where the child lives. And so liaison and communication has to happen, and really good communication, both written and verbal communication, has to happen. So that's one thing. Secondly, obviously the acute things have to be resolved. So Thomas's opportunistic infections have to be treated. His diarrhea has to have ceased. He's got to be feeding well and gaining weight again. His oral thrush has to be resolved. He has to have commenced on ART, both Thomas and his parents. And usually when children are commenced on ART, it's important to just take time, take some days to educate parents about ART, about the way they give it, the frequency with which they give it, to model them giving it to the child and taking it themselves. And if they get any side effects, just explaining those. There are many people, children, adolescents, adults, who will stop ART because of some side effects, and so many of those side effects can be dealt with, and it's just important that parents know that ART is lifelong. It needs to be every day, and it needs to be all three drugs. They can't just stop one of the drugs or two of the drugs and stay on one, because then the rates of resistance are very high. So there's a number of really fundamental education points, talking points that you need to have with families, and that takes time, many days of counselling and education for these children, and they need to be linked with the outpatient clinic where most of their HIV care will be provided, and to know that there are experts in HIV who are there, who are looking after them, and they need to have a contact point in the hospital or in the clinic, a person they can call to ask questions. Very important, because otherwise they will end up being uncertain about certain things and making making bad decisions about their treatment if they can't get their questions clarified better. Outpatient monitoring and follow-up is what HIV care has become to be largely about, because most children living with HIV now are diagnosed before they get opportunistic infections. They're diagnosed at the time of birth or soon after birth, and they need to be attending regular maternal and child health clinics just like other children, and they need monthly follow-up to monitor their ART adherence and complications, their growth and nutrition, their immunizations, and making sure they're safe. Their family, it needs to be whole of family support, with social support for their family and attention to their development and psychological well-being of the child and the family, and to identify other infections that might occur along the way. There's a whole holistic approach to the management of HIV, which is not just holistic for the child, but it's a family orientated holistic approach where it shouldn't be that the parents get their treatment at one clinic and the child in another. Really, ideally, a sort of a family clinic where all the care can be given and education and support can be given. So in summary, the management of children with HIV is most like that of other sick children, except it does have other dimensions, including a focus on chronic continuous care, a focus on adherence of medications, on much more education for families than is required for acutely unwell children. And it goes without saying now that antiretroviral therapy has improved the lives of so many countless children affected by HIV, and it's gone from a disease for which there was nothing that could be done apart from palliative care, to a disease where children can get near or full immune reconstitution and lead very otherwise normal lives while they're taking their antiretroviral therapy. But there's been, in the last decade, there's been increasing rates of resistance, and drugs have changed. So I'm sure it will change again in the next 10 years. The third edition of the Pocketbook of Hospital Care for Children being written now includes many of those, all of the changes that have happened in the last 5 or 10 years. Now, as I said, all children living with HIV should be on dolutegravir-based therapy, DTG-based therapy. That's fundamentally important, that they be on an integrase inhibitor as part of their treatment. Abacavir, lamivudine, dolutegravir is the standard. For 25 years, we've known that cotrimoxazole prophylaxis is good for children with HIV, and that remains so. Even with more effective antiretroviral therapy, it's still important that children, at least for the first 5 years, and usually into adolescence, remain on cotrimoxazole, Septrin or Bactrim. And I guess HIV is one of the earliest conditions for which chronic care was very became a very important system, systematized, and the chronic. These days, many children have other chronic illnesses, not HIV, other chronic respiratory illnesses or cardiac illnesses or other things. And hospitals have learnt a lot from the management of HIV, the holistic approach to care. And I think then it's clear that all children living with HIV need sort of continuity of care. They need trusted healthcare workers who know them and their family very well, and they have to trust that they'll provide that care so that they maintain adherence with medications and remain well. So that's all I want to say about HIV and the HIV chapter. It's a long chapter in the Pocketbook of Hospital Care for Children, and you can read it. It's more details than what I've described today. So thanks everyone for your attention about this and the other teaching modules as part of this course. Get a copy of the Pocketbook of Hospital Care for Children and see and use it in the care of your patients, and please take good care of your patients. So thanks everyone.